Lung, normal cells. Ciliated columnar bronchial cells, goblet cells, squamous cells, reserve cells, which look like lymphocytes, alveolar macrophages. Type 2, or granular or alveolar pneumocytes. Plump cuboidal cells that secrete surfactant. Cells are round and have vacuolated cytoplasm and look like macrophages. Can look like adenocarcinoma when reactive, but groups are flat and have lobulated outlines. Adenocarcinoma is more three-dimensional with smooth borders of cell clusters. Lung, insufficient, inadequate, or non-diagnostic. Poorly prepared or poorly visualized slides. Cellular material doesn't correlate clinically. In sputum, alveolar macrophages and ciliated columnar cells are required. In bronchial washing or bronchi-alveolar lavage, 20 alveolar macrophages per 10 high-power fields. Bronchial epithelial cells shouldn't exceed macrophages. In bronchial brushing, abundant bronchial epithelial cells and may have macrophages. In EBUS FNA biopsy, reactive bronchial ciliated cells, or greater than 40 lymphocytes in highest cellularity area. In transthoracic FNA biopsy, alveolar macrophages with carbon may have hemosiderin, may have bronchial epithelial cells, may have reactive type 2 pneumocytes, may have tissue fragments of collapsed alveolar septa. Lung benign, acute inflammation or suppuration. Neutrophils in degeneration predominating in fibrinous, proteinaceous background or no degeneration. Inflamed bronchial tissue fragments or alveolar fragments in FNA biopsy. Varying macrophages, eosinophils, lymphocytes, plasma cells. Debris in background, bacteria. Aspiration pneumonia, pus, foreign body, vegetable or muscle fragments, giant histiocytes, squamous metaplasia. Pulmonary infarct, hemosiderophages, hyperplastic bronchial cells with atypia, may have neutrophils or macrophages. Lipoid pneumonia, lipid-laden macrophages and neutrophils. Lung benign, histiocytic, lymphocytic, or eosinophilic inflammation. Histiocytic pattern, varying histiocytes, including giant histiocytes, can contain lipid, hemosiderin, surfactant, dust, or mineral fibers. Lymphocytic pattern, many and different types of lymphocytes, varying morphology, may have plasma cells, histiocytes, or eosinophils. Eosinophilic pattern, many eosinophils may have Charcot-Leyden crystals. Lung benign, granulomatous disorders. Epithelioid histiocytes with grouped uniform nuclei, giant histiocytes, and lymphocytes. Epithelioid histiocytes have elongated indented nuclei, fine chromatin, often syncytial cytoplasm. May have necrosis, granular and caseous or non-caseous, often central. May have hyaline sclerosis around granulomas. Lung benign, inflammatory or reactive changes. Includes bronchial cell hyperplasia, basal cell hyperplasia, squamous metaplasia, viral cytopathic changes, chemo and radiation. Chemo changes usually resolve shortly after finishing. Radiation changes can last years. Bronchial, reactive, or repair changes. 3D or papillary groups, cilia or terminal bars may be lost, can have abnormal nuclei in a ciliated group. Type 2 pneumocyte hyperplasia. Large cell, small cell, or small groups with knobby borders, some large nuclei with large nucleoli, may have vacuolated cytoplasm. Lung benign neoplasm, pulmonary Hamartoma. At least 2 mesenchymal elements with entrapped respiratory epithelium. Biphasic pattern of fibroid myxoid stroma and epithelium at low power. Wispy fibromyxoid stroma with feathered outlines, contains bland fusiform or stellate cells. Epithelial cell component can be prominent. Sheets can be metaplastic, can be atypical. Cartilage usually sparse with possible nuclear variability but no atypia. Can have adipose tissue, bone, or muscle. Lung benign neoplasm, sclerosing pneumocytoma. Variable cellularity, tissue fragments or dispersed cells. Papillary fragments with stromal cores underneath cuboidal cells with nucleoli. Sheets or acini with hyalinized stromal fragments may be seen. Two populations, surface polygonal or cuboidal cells with vacuolated cytoplasm, and round or spindle stromal cells with dense cytoplasm. May have nuclei with atypia, anisonucleosis, intranuclear pseudoinclusions, grooves, and indistinct nucleoli. Mitoses are rare. May have cholesterol crystals. No necrosis or malignant features. Bloody background with hemosiderophages and multinucleated giant cells. Lung benign neoplasm, solitary tracheobronchial papilloma. Squamous type, tissue fragments and keratinizing and non-keratinizing squamous cells. May have anucleate squames. No necrosis. Background of inflammatory and keratinaceous debris. Coilocytes, which may be dysplastic, usually no mitoses. Glandular type, tissue fragments or single, enlarged, or hyperplastic columnar cells with cilia. Rarely has both glandular and squamous components. Lung benign neoplasm, salivary gland neoplasms. These include pleomorphic adenoma, myoepithelioma, and oncocytoma. Lung benign neoplasm, perivascular epithelioid cell tumor, or PEComa. Moderately cellular, tissue fragment traversed by thin capillaries and scattered spindle cells. Bland cells, round to oval nuclei, mild anisonucleosis, no atypia or mitoses. Intranuclear pseudoinclusions are rare. Blood, lymphocytes, macrophages, many single round oval naked nuclei in background. Found in elderly, associated with tuberous sclerosis and lymphangioliomyomatosis. Lung benign neoplasm, spindle cell tumors. These include schwannomas, pulmonary hamartomas, fibromytoses, leiomyomas, solitary fibrous tumors, and inflammatory fibroblastic tumors. Lung benign neoplasm, meningiomas. Hypercellular, cohesive sheets or fragments, may have whorled pattern. Spindle or epithelioid cells with elongated or fusiform nuclei. Single cells with wispy cytoplasm. Fine chromatin, small nucleoli, some intranuclear pseudoinclusions, can be degenerated and atypical. May have psammoma bodies. Mitosis and necrosis, usually only in high grades. Lung benign neoplasm, granular cell tumor. Moderate cellularity, loose sheets, some single cells. Medium to large monomorphic oval to round polygonal cells. Abundant eccentric eosinophilic fragile cytoplasm, granules in background. Nuclei small to medium, round, with some small nucleoli. No necrosis or mitoses. Rare malignant form has necrosis. Lung benign neoplasm, ectopic thyroid and ectopic parathyroid. Parathyroid, usually adenomas, hypercellular epithelial cells with round nuclei, clear clear to slightly dense cytoplasm in sheets or acini, may have fine blood vessels and tissue fragments, may have papillary tissue fragments. Thyroid, follicular nodular disease, goiter, follicular neoplasm, or papillary thyroid carcinoma may be found. Lung atypical. Atypical epithelial reactive or repair changes. Metaplastic changes unable to differentiate from a neoplasm. Scant, very atypical cells. Background suggestive of a neoplasm, such as necrosis, keratin debris, thick mucin, or apoptosis. Bland spindle cell neoplasms that require ancillary studies. Lung, suspicious for malignancy. Suspicious cells, but limited by cellularity, preservation, etc. Lung malignant adenocarcinoma. It's the most common primary malignancy of the lung. Cells are found in flat sheets, spheres, papillae with fibrovascular cores, acini, glands, pseudopapillae, and micropapillae. Glandular or acinar fragments have peripheral or basal nuclei, more central cytoplasm. Small tumor cells can exfoliate from the surface of tissue fragments. Sheets with a variable loss of polarity may contain acini-like rosettes or true luminal space. Cells are cuboidal to columnar with moderate to abundant cytoplasm, which may be homogeneous, granular, foamy, or vacuolated. Fine vacuoles are more common than large vacuoles with mucin. Large, round to oval nuclei, fine to coarse chromatin, often not hyperchromatic. Nuclear membranes can show minor atypia, may have intranuclear pseudoinclusions and grooves, especially in well-differentiated. Poorly differentiated may have pleomorphic chromatin and nuclear shape. Single or multiple large or prominent nucleoli. Background may have necrosis, mucin, or psammoma bodies. Can have goblet cells in enteric and mucinous adenocarcinomas. Poorly differentiated, non-keratinizing squamous cell carcinoma. High cellularity, necrosis, cohesive flat sheets, or three-dimensional fragments, may have single cells. Well-defined or dense cytoplasm can be elongated or spindled with occasional keratinized cells. Nuclei central or elongated or pleomorphic with dense irregular chromatin and prominent nucleoli. Lung malignant basaloid squamous cell carcinoma. Cohesive sheets or irregular tissue fragments, variable palisading at margins, small to medium high NC ratio cells, round to oval to angulated nuclei, dense coarse chromatin, inconspicuous nucleoli, scant cytoplasm rim, may have some nuclear molding, may have pseudoglandular spaces, pseudorosettes, nuclear palisading, necrosis, nuclear crush, and stromal hyaline basement membrane material wrapping fragments. Lung malignant, non-small cell not otherwise specified, or NOS. Cellular tissue fragments in single cells. Crowded tissue fragments that do not have morphological features of glandular or squamous differentiation. Pleomorphic large single cells with large pleomorphic nuclei and prominent nucleoli. Often has necrosis, but without mucin or keratin debris. Lung malignant, salivary gland type carcinomas. Mucoepidermoid is the most common. Next is adenoid cystic carcinoma, followed by epithelial, myoepithelial carcinoma, acinic cell carcinoma, and others. These are rare, 0.1 to 0.2% of lung neoplasms. Lung malignant Adenosquamous Carcinoma, loosely cohesive tissue fragments or single cells, with features of squamous cell carcinoma and adenocarcinoma, with necrosis. Some keratinized cells. Some cells with perinuclear clearing, prominent nucleoli, and intracytoplasmic mucin. Lung malignant Pleomorphic Carcinoma, discohesive enlarged pleomorphic round to spindle cells with blue-gray cytoplasm on pap stain. May have tumor giant cells with 2 or more nuclei. Large nucleoli. Background with necrosis and inflammation. May have myxoid or collagen-rich stroma. Lung malignant Pulmonary Blastoma, cellular with 2 or more cell populations. Adenocarcinoma cells with uniform single nuclei and subnuclear vacuoles. Squamoid cells in sheets or morules, large with well-defined cytoplasm and no keratinization. Sarcomatous cells that are small or homogeneous, have high NC ratios, and hyperchromatic nuclei. Lung malignant carcinosarcoma, highly cellular biphasic cell populations. Single cells or tissue fragments of adenocarcinoma, squamous cell carcinoma, or undifferentiated carcinoma. Malignant spindle or giant cells with 1 or more nuclei. Stromal heterologous differentiation. Primitive skeletal muscle single cells or loose tissue fragments and or malignant bone or cartilage tissue fragments. Hyperchromatic large pleomorphic nuclei, often has irregular large nucleoli. Necrosis. Lung malignant nuclear protein in testes or NUT carcinoma. This is found in ages 0 to 80 and is defined by the NUT gene rearrangement. Very cellular, loosely cohesive tissue groups and single cells, round to oval cells 2 to 3 times the size of a lymphocyte, high NC ratio, cytoplasm usually scant or delicate and rarely vacuolated. Nuclei with fine chromatin, prominent nucleoli, mitoses, may have nuclear molding on cytospins. Often has infiltrating neutrophils. Background with necrosis, karyorrhexis, naked nuclei, and chromatinic smearing. Rare squamous differentiation. Lung malignant, thoracic, SMARCA4 deficient, undifferentiated tumor. Hypercellular, loosely cohesive sheets or single cells. Cells are round, oval, or polygonal, intermediate sized, often monotonous but sometimes pleomorphic, with prominent cell borders or poorly defined fragile cytoplasm. May have rhabdoid morphology with globular eosinophilic perinuclear inclusions or cytoplasmic condensation. Enlarged round to oval nuclei, can be irregular with perinuclear clearing and prominent nucleoli in cells with eccentric cytoplasm. Mitoses. May have apoptoses and streaking artifact. Background usually necrotic or inflammatory. May have giant cells, naked nuclei, or multinucleation. Found in males and smokers. Lung malignant carcinoid or neuroendocrine tumors, highly cellular, discohesive sheets, large tissue fragments, plexiform branching or thin fibrovascular strands surrounding or attached to sheets, trabeculae, cords, single cells, papillary or acinar structures. Pseudo-rosettes are common. Stripped branching fibrovascular strands without neoplastic cells can be present. Uniform round, oval, sometimes spindle cells. Eccentric or central nuclei, which are round to oval with smooth membranes and salt and pepper chromatin. Cytoplasm is granular, may be oncocytic, or have melanin. Naked nuclei in background. May have binucleation, intranuclear pseudoinclusions, or nuclear grooves. Lung malignant, small cell lung carcinoma. Crowded tissue fragments and discohesive cells. May have pseudo-rosettes, may have blue bodies on Giemsa stain. Cells 3 times the size of lymphocytes, with scant cytoplasm. Angulated nuclei with nuclear molding and crush. Finely granular chromatin, occasional small nucleoli. Mitoses, apoptoses, and necrosis in background. Lung malignant, large cell neuroendocrine carcinoma. Cellular, small tissue fragments, single cells, and necrosis. Thin fibrovascular strand may be in tissue fragments. Cells usually more than 3 times lymphocyte size, with moderate to abundant cytoplasm. May have nuclear molding. Usually granular fine chromatin, may be coarse or have perinuclear clearing. Inconspicuous to large nucleoli. Chromatin smearing is common. Necrosis and mitoses. Lung malignant, lymphomas. Extranodal marginal zone lymphoma of Malt, or EZML, is 70 to 90% of pulmonary primary lymphomas. Found more in females, smokers, and people with autoimmune disease. It has small lymphocytes, centrocytes, monocytoid cells, plasmacytoid cells, and may have amyloid. Diffuse large B-cell lymphoma is 10% of primary pulmonary lymphomas. It has monotonous, intermediate, and mostly large lymphoid cells, perinuclear clearing, single or multiple nucleoli, and mitoses and apoptoses. Lung malignant, pulmonary Langerhans cell histiocytosis. Cellular. Langerhans cells are single, large, with abundant, delicate, finely granular cytoplasm, and elongated pale nuclei, with many nuclear grooves and folded nuclear membranes. May have variable size in isonucleosis and bi- or multinucleation. Eosinophils and other inflammatory cells in background, and may have Charcot-Leyden crystals. No phagocytosis. Found in smokers, and the mean age is 40. Lung malignant, Erdheim-Chester disease. This is a rare histiocytosis. Loosely cohesive and single histiocytes with moderate foamy cytoplasm. May have multinucleated or Teuton-type giant cells. Histiocytes have oval or kidney-shaped nuclei with no grooves. Nuclei may be naked. Background may have inflammatory cells such as lymphocytes or plasma cells, or metachromatic fibrotic material. Lung malignant, spindle cell tumors. Spindle cells with dissociation, high cellularity, necrosis, and mitoses. Lung malignant, paraganglioma. Very rare neuroendocrine neoplasm may produce catecholamines. Loosely cohesive or syncytial tissue fragments are three-dimensional and follicular, acinar, or nested. May have single cells and naked nuclei. Bloody background. Medium epithelioid or spindle cells of varying size. Single cells can have granular cytoplasm. Round to oval nuclei, even chromatin, micronucleoli, may have anisonucleosis. Some larger cells with pleomorphism, nuclear grooves, intranuclear pseudoonclusions, and bi- or multinucleation. Lung malignant, diffuse pleural mesothelioma. High cellularity, tissue fragments and single cells. Berry-like morular, papillary, or tubular fragments. Papillary fragments may have collagen cores. Pleomorphic and multinucleated cells. Enlarged nuclei, macronucleoli, atypical mitoses, pseudoparakeratosis, perinuclear lipid vacuoles. Hyaluranon on background is mucin-like. Lung malignant, primary germ cell tumors of the mediastinum. These include seminoma, embryonal carcinoma, yolk sac tumor, choriocarcinoma, mature teratoma, immature teratoma, and mixed germ cell tumors. Many are discohesive and obviously malignant. Lung malignant, primary angiosarcoma of lung. This is rare and associated with previous radiation, especially to breast. Single cells, irregularly outlined loose tissue fragments, and fragments with irregular vascular spaces. Elongated spindle cells with oval nuclei and indistinct borders arranged in poorly formed fascicles. Epithelioid, plasmacytoid, or polygonal cells with abundant cytoplasm and distinct borders. Coarse chromatin, irregular nucleoli. Cytoplasmic vacuoles with red blood cells or leukocytes. Hemosiderophages. Lung malignant, pulmonary and thoracic metastases. Adenocarcinomas are the most common metastases. This includes breast, colorectal, and renal cell. And along with head and neck cancers, these are the most common metastases to lung. Almost any cancer can metastasize to lungs. Metastases are peripherally located, bilateral, and multiple nodules with smooth borders. Head and neck squamous metastases may be cavitated. Primary tumors are often spiculated masses. 95% of pediatric pulmonary malignant tumors are metastases. Primary lymphoid neoplasms are less than 1% of lung tumors. Most lymphoid malignancies in the lungs are metastases.